Good morning. It is Wednesday, May 5th, 2021. We are at our second to last lecture, so we are rapidly approaching the end of this. We are going to continue our discussion of the reproductive system today, and my goal is to finish the female version of the reproductive system so that on Monday next week, we can focus on development. And again, there are development classes where you spend a whole semester talking about these things. So obviously we're not going to get to go anywhere near as in depth as we would like to, something like this, but we'll focus on the very beginning of the process and the very end of the process and kind of leave the rest in between for those who want to take that class. This is your big study weekend. Your exam is next week, 1 week from today. So please do remember to take advantage of that to help to encourage you to work on that. You do still have 2 more assignments you are responsible for, your Unit 27 review and one last labster on Mendelian genetics, which is always a lot of fun. And then it's all tests all the time. 1 week from today, you have your last lab and lecture exam. You've already taken 4 of those. Some of you have already taken 9 of those from me. So you know what to expect from this. There's no surprises, nothing different. Everything is the same as it ever was on that. There is no class on the 17th. I just want to clarify that. That is considered finals week. So I will have my normal office hours. I may have some additional office hours. It'll depend on how the week goes. But definitely I'm able to respond by emails, and appointments can be made if those office hours don't work for you. But you have a test with me on the 12th, and then 1 week later, you have your 100-point cumulative final exam. Again, those of you who took me for 430 know what that's like. It's just 100 multiple choice questions. You have about 100 minutes to take it. It is covering everything that we've covered in this class. It counts as a grade on its own. And remember, it also can replace your lowest lecture score. All right, so questions on any of that? I think at this point, hopefully all of that makes sense and we are prepared for that. All right, excellent. So let's pick up where we left off. We left off last class and we were kind of working our way through this table. We had focused primarily on oogenesis, which technically isn't on this, but we know is also related to the events that are happening in the ovary with the follicles themselves. And so we talked about that ovarian cycle and the maturation of the follicles, the ovulation of the follicle, the transformation of the follicle, and the continuation of that cycle. And one of the things that we hinted at in this process, but again, I want to make sure we spend some time talking about and emphasizing, is the hormones involved. Both the hormones that drive this process, luteinizing hormone and follicle stimulating hormone, and the hormones that are produced by the ovaries as well, the estrogens and the progestins, because they have, unlike the males, there is a very complicated relationship between the hormones that are produced by the anterior pituitary and the hormones that are produced by the ovaries. So I want to spend some time talking about that. Also, as we mentioned, we need to establish the ovarian cycle, start this process. And once again, unlike the males, it's a little bit more complicated in this process. During and throughout childhood, the female's ovaries are secreting a very small amount of estrogen and a very small amount of inhibin. And estrogen has a very complicated relationship with the anterior pituitary. At low levels, estrogens inhibit the production and the release of the gonadotropins, a gonadotropin production and release in the anterior pituitary. And of course, inhibin does the exact same thing. So between these estrogens and these inhibins, we are suppressing the production of our follicle stimulating hormone and luteinizing hormone. But then a female becomes sexually mature. And part of that sexual maturity, what drives that sexual maturity, is the female's body being physically capable of not just producing eggs, but more importantly, being able to sustain that egg. Because unlike the males who are just producing chromosome missiles, remember the females get the honor and the privilege of not just producing a gamete, but then housing that gamete as it divides into trillions of cells and becomes a little viable basketball. So the female's body needs a way to be able to tell the anterior pituitary, hey, I am healthy and mature enough to be able to produce and house an offspring. And the way they do that is with the hormone leptin. Remember, we talked about leptin once before. What cells produce leptin? Someone remind me?
Adipose?
Adipose, absolutely. Right. We talked about leptin being produced by adipose primarily as a appetite suppressant. We talked about how it decreases appetite. And when they first discovered that, they thought they had the miracle pill, right, for weight loss. However, as we learned, being hungry is not one of the main factors that drives people to eat. All sorts of other things do. Timing, convenience, stress, all sorts of other things cause people to eat, not just being hungry. And so, again, didn't pan out to be the miracle diet pill, but as it turns out, it is a vitally important hormone in females. It's females' basically body's way of letting the hypothalamus know, I am both mature enough and, more importantly, healthy enough to be able to house an offspring. Developing a baby inside of you is a tremendous metabolic strain on the female body. Basically, you become a baby oven. Your metabolism is turned up to 11, right? And so being able to have those resources readily available to be able to sustain both yourself and that growing baby is vitally important. So having enough adipose to produce enough leptin is important, and that stimulates the hypothalamus. And of course, then our hypothalamus is going to produce and release our gonadotropin releasing hormones. And when it starts producing and releasing gonadotropin releasing hormones, of course, that means that our anterior pituitary is going to start to produce and release follicle stimulating hormone and luteinizing hormone. I think we've written those things out enough in the past couple of days where I can get away with abbreviating them without that being too much of a cheat. All right. Now, obviously, this process is going to take some time to establish itself. And in fact, for a female, it may be, a year or more before a full normal ovarian cycle is produced. Right. So during the first couple years of puberty, the female may have dramatically varying times between her menstruations. She may skip a month. She's not always going to ovulate every month on cycle as well. Does that mean that it's perfectly okay for that 13-year-old to have unprotected sex because she's not as likely to release, say, an egg, a secondary oocyte during that cycle? No, of course not. Absolutely not. Absolutely. Are there instances, unfortunate instances, where a female during her first menses ovulates and it's fertilized and becomes pregnant? Sure, absolutely. So again, it can occur. It's not a viable form of birth control, as we've talked about, but it can be very irregular during that time. But ultimately, eventually, over time, and again, they can be infertile, but again, also cannot be infertile during that time. Eventually that adult cycle is established. So with some growing pains going on with that, a lot of flexibility, a lot of strain, a lot of function, we establish a relatively stable hormonal cycle. All right, so let's talk about that hormonal cycle. Let's see what we have on the next slide. Yeah, so let's do this. With only 2 classes left, I'm running out of opportunities to draw. So let's go ahead and do some of that. This is not going to be ideal, but we'll make it work. So what we're going to do up here is we are going to look at the hormones of the anterior pituitary. And down here, we're going to look at the hormones of the ovary. What are the two main hormones we're interested in here again on our in our anterior pituitary that drive this process? It's going to be a horrible graph, but we'll make it work.
Follicle stimulating hormones and luteinizing.
Exactly. Excellent. So our follicle stimulating hormone. And again, I'm just going to abbreviate these because we've been talking about them long enough where I can cheat for that. And then our luteinizing hormone as well. Excellent. Whereas, what are the two classes of hormones that we care about in our that are being produced by our ovaries?
Estrogens and progestins.
Excellent. Progestins. Excellent. Now, as we also talked about, our cycle, typical cycle, average cycle, as we've talked about, is 28 days. Although, as we mentioned, it can vary from female to female, but we'll use that as a nice average. So we start here at day 1 and go to day 28. Now, as we've already talked about the ovarian cycle, what do you think the most important event of the ovarian cycle is?
Ovulation.
Ovulation, absolutely, because that is what drives the process. That's the purpose of the process. That's what propagates the species. So obviously ovulation occurs at day 1, right? Because after all, it's the most important event. That's when we would want to start our timer from, correct? No, when did we say that occurs?
11-14-ish.
Yeah, around day 14, absolutely. That seems kind of odd to do it that way. Why do we do it that way? If that's the most important event, why set it at such an odd time?
Because you have to prepare.
True, some of it is preparing. That is worthwhile. Of course, that might require a little bit of sense from the standpoint of our anatomists, right?
It's easy to know when you're menstruating, not when you're ovulating.
Exactly, right? We have a fair number of females in this class. Does anybody know the very last time they ovulated? Can anyone give me a date? Time of day? Week? Right? No, exactly, right? However, of the females in here, how many of you are capable of knowing when the very first day of your last menses was? Right? Again, it's a much more exactly. So while menses might not be a more important event, it absolutely is a more observable one from the outside world. And so it is that easily identifiable date, the onset of menses, that we typically use as day 1. Now, we will talk about the uterine cycle and what's going on with there, the menses and the regrowth that occurs. But at day 1, when that menses is occurring, basically all of our hormone levels are relatively low. So for the female, and let's use some different colors here. For estrogens, we'll use dark red. For progestins, we'll use pink. For our luteinizing hormone, we'll use dark blue. And for our follicle stimulating hormone, we'll use light blue. All right, so the hormone levels of all these, and actually my luteinizing hormone might be a little high, so let's cheat and move that down. Oops. Not sure what just happened there. Oh, that's weird. All right, let's just get rid of that. All right, so at the onset, day 1 menses, the hormone levels are relatively low. Now, as we talked about, there are some complicated relationships here, and those primarily involve the fact that, as we talked about, at low levels, estrogen and progesterone inhibit luteinizing hormone, and well, let's do it with the inhibit the anterior pituitary. All right. Now, if estrogen and progestin levels are really, really low, then at the onset of this process, there is little to no inhibition on the anterior pituitary. So as a result of that, the anterior pituitary is going to start to produce luteinizing hormone and follicle stimulating hormone. So levels of luteinizing hormone are going to start to increase. Levels of follicle stimulating hormone are going to start to increase. So we start to see this increase in the levels of these things during the beginning of this process. Now, as we know, that increase in follicle stimulating hormone is going to trigger the maturation of those primordial follicles. So our primordial follicles are going to start to mature, and our follicles grow bigger and more numerous, and we start to get the formation of granulosa cells. And someone remind me what granulosa cells do?
They secrete hormones,
Yes, what hormone particularly?
the androgens, sex hormones.
Well, true, but then, okay, so it triggers the thecal cells to do that, but then the thecal cells, the granulosa cells, convert those androgens of the thecal cells into what?
Estrogen.
Estrogens. So what starts to happen is as we have more granulosa cells, we have more estrogen being produced. Now, as estrogen levels increase, as we talked about, it has this complicated relationship with the anterior pituitary, where what happens is it inhibits the release of follicle stimulating hormone and luteinizing hormone, but not production. So our anterior pituitary is still producing luteinizing hormone and follicle stimulating hormone, but they're not releasing them. So the levels of these start to stabilize. And in fact, if you remember, one of the things we talked about is that not only does the luteinizing levels stop increasing because less is being released, but remember we mentioned how follicle stimulating hormone levels will actually drop. Remember how we talked about that drop of follicle stimulating hormone levels is what leads to the attrition of the number of follicles. So the dozens of primary become a handful of secondary and eventually only become one tertiary. I like that. Let's write that down. But remember, this tertiary follicle is huge. with lots of granulosa cells. So while the number of follicles decrease, the amount of estrogens being produced, the number of granulosa cells continue to increase. And so as a result of that, estrogen levels continue to climb. Now notice this whole time, have we been producing any progestins? In fact, I should probably have dropped that all the way down there. There we go. So answer my question. Have we been producing any progestins during this time? No, excellent. No, so again, because again, the follicle cells only produce estrogens. All right. Now, as I mentioned, estrogen has a complicated relationship with the anterior pituitary. As we talked about, at low levels, it inhibits it. However, it reaches a critical point. And when estrogen levels reach that critical point, what ends up happening is instead of inhibiting, it now triggers the release of all that stored hormones. And so as a result of that, we get a spike of follicle stimulating hormone that is released. And more importantly, a major spike, which is going off the chart here, of our luteinizing hormone. And that major spike of luteinizing hormone just happens to correspond with what time? How about day 14? And that huge spike of luteinizing hormone triggers what event in our ovary? Excellent. Triggers ovulation. Oops. Excellent. All right. Now, ovulation occurs at day 14, but that luteinizing hormone does something else. What else does luteinizing hormone do? It's in the name. Luteinizing hormone. Luteinizing hormone sounds like it luteinizes something. What does it luteinize?
Corpus luteum.
Yeah, basically what it does is it transforms the granulosa cells that stayed behind into the corpus luteum. Absolutely. And what does that corpus luteum do that the granulosa cells didn't? What does our corpus luteum do that our granulosa cells don't?
Produce estrogens and progestins.
Produce progestins, absolutely. Both already produced estrogens, and the estrogen production will continue. Now, obviously, disrupting the follicle is going to lead to a disruption. So you will see a slight drop, but then estrogen levels will start to come back up again. But you are absolutely correct. What we're doing now that we weren't doing before is now starting to produce progestins. and we're going to produce massive amounts of those progestins. Remember, those progestins are the warning bell hormone that tells the female body it is time to get ready for being pregnant. So, massive production of progestins, estrogen production continues. And that's a bit of a problem because estrogens and progestins together inhibit both production and release of follicle stimulating hormone and luteinizing hormone. I have to cheat. Oops, no, not you. You get to stay there. You get moved. So what happens is we start to see a drop in the luteinizing hormone levels. We start, actually, I guess the way I've drawn this, I got to extend it out a little bit longer. There we go. Drop of luteinizing hormone. Again, my drawing skills are not the best. You guys appreciate and understand that by this point in time, but you get the idea. Follicle stimulating hormone levels start to drop, and they start to decrease in both production and release. And that's a problem because our luteinizing hormone produces and maintains the corpus luteum. So if luteinizing hormone starts to go away, what happens to my corpus luteum?
Becomes a corpus albicans.
Yeah, as the luteinizing hormone goes away, our corpus luteum degenerates. And of course, as it degenerates, it produces less hormones. So as a result of that, we start to see a drop in progestin levels. We start to see a drop in estrogen levels. And of course, when estrogen and progestin levels drop, oh, until you're right, hold on. Let's go back. Ultimately, corpus luteum becomes corpus albicans. And when it produces corpus albicans, basically hormone levels have dropped all the way down. And of course, with low levels of estrogen and progestins, the anterior pituitary is no longer inhibited, and follicle stimulating hormone and luteinizing hormone are produced and released. Which sounds an awful lot like what just happened. The cycle continues. We start to see a rise in our follicle stimulating hormone levels. We start to see a rise, in our luteinizing hormone, which stimulates the follicles, and the whole process begins anew. So again, I've done an okay job of drawing this as best as I can with my limited skills, but if we cheat and go back 2 slides, here we see that process. We'll go through it in the pretty words in just a second, but let's go over with the pretty pictures. Notice we have an increase in our luteinizing hormone and follicle stimulating hormone. As these levels go up, estrogen levels start to go up. Notice not progesterone because they stay down. As estrogen levels increase, we have a tapering of our luteinizing hormone and actually a decrease in our follicle stimulating hormone because release is blocked, but not production, until we reach that trigger point where estrogen levels get high enough where it actually triggers the release and we get that huge spike, and that huge spike causes ovulation. It also causes the transformation of the remaining follicle into the corpus luteum. And the corpus luteum does something that the follicle didn't, producing progestins. Right? There's a disruption in estrogen, but then estrogen levels start to come back up. And this estrogen and progesterone together inhibit not just the production, not just the release, but also now the production of follicle stimulating hormone and luteinizing hormone. As luteinizing hormone levels decrease, our corpus luteum goes away. As our corpus luteum goes away, estrogen and progestin levels drop, inhibition gone, and the process starts all over again. So our pretty picture shows this as well. No, the spike in luteinizing hormone basically does two things. Yes, there's a spike in follicle stimulating hormone, but it is not as significant to the effect. What happens at ovulation that really is the effect we care about is the spike in luteinizing hormone. Because the spike in luteinizing hormone does two things. Obviously, it triggers ovulation, so the egg is released so that we can propagate our species. But the other thing it does is these remaining cells of the follicle, these granulosa cells that were forming the wall of the follicle, get transformed into the corpus luteum. And the corpus luteum is a big, huge gland. And this gland produces massive amounts of progesterone and some estrogen. It produces both. So we get the increase in progesterone and the increase in estrogen because of the formation of the corpus luteum. But that's the problem. When the corpus luteum goes away, the estrogen and the progestin goes away. And that's what causes the cycle to continue. So here we've looked at it with the pretty pictures. Let's look at it with the pretty words. Again, our hypothalamus stimulates the release of follicle stimulating hormone and luteinizing hormone. Stimulates our follicles to grow. Estrogen is produced and released, as well as inhibin. And as we talked about, at the low levels, that estrogen inhibits just the release, right? Not the production. So the anterior pituitary is still making follicle stimulating hormone and luteinizing hormone. It just can't release it. So it's storing it up. And that's how we're able to have that massive spike of it, because they just can't release it, but they can still make it. Continue to synthesize it. It continues to accumulate. Remember that luteinizing hormone and follicle stimulating hormone levels off. And as we also talked about, follicle stimulating hormone will actually drop. And that's what leads to the attrition of our follicles. Why we go from dozens of primary to only a single tertiary. But that single tertiary follicle is massive, made up of thousands of granulosa cells that start producing high levels of estrogen. And those high levels of estrogen lead to that massive release of luteinizing hormone. Yes, there's a spike of follicle stimulating hormone as well, but A, it's a smaller spike, and B, we don't care. It's the luteinizing hormone that we care about, because luteinizing hormone does two things. The first important thing that it does is it triggers that ovulation. The rupturing of the follicle, the release of the egg. But it also does a second equally important thing. It transforms the remaining granulosa cells, that ruptured follicle, that burst balloon, it transfers it into this massive glandular structure known as the corpus luteum. And that corpus luteum produces not just estrogens like the granulosa cells did, but it also produces progestins. And of course, the primary progestin is progesterone. The problem is this progestins and this estrogens inhibit, in this case, both production and release. So it's not just making it and storing it. Now it's not making it and not releasing it. So follicle stimulating hormone and luteinizing hormone levels fall. And that luteinizing hormone doesn't just produce the corpus luteum, but it maintains it as well. So without luteinizing hormone, we can't have a corpus luteum. And if the corpus luteum starts to go away, it stops producing estrogens and progestins. And when the estrogens and progestins go away, the inhibition of the anterior pituitary goes away, and the cycle starts again. I warned you this was the Lexus version of things. More bells, more whistles. All right. Questions?
Question.
Yes, go ahead.
Okay, so the estrogens have both a positive effect on the release of LH and a negative effect, right?
Yes.
So with the huge spike causing more of a release, does that mean estrogen's positive effect is more pronounced than its inhibitive effect?
No, the effect here, hold on, whoops. Let me see if I show you that slide again. Here we go. This is the one that I want. The effect that estrogen has on the anterior pituitary is based on the amount of estrogen. So basically what there is there is this threshold. And I'll cheat here, move it up like this. If estrogen levels are below that threshold line, it is inhibitory. If it is above that threshold line, it is excitatory, where it triggers that release. So it is only when it comes up to, wow, that is a huge arrow. It is only when it comes up to this trigger point where it reaches above a certain threshold that it becomes excitatory, that it stimulates the release. Of course, notice it then immediately drops back below that level and doesn't get back up to it again. So the rest of the time it's going to be inhibitory. And remember, we talked about how estrogen inhibits release, but progestin levels, which are also very high, also inhibit production. So together, the estrogen and progestins inhibit both production and release of the luteinizing hormone and follicle stimulating hormone.
Okay, so only at certain threshold levels does the anterior pituitary respond differently to the hormones?
Correct. And don't ask me why. I don't know. It's just the way that it is.
Can we go back to your other table that you hand draw for like just a second?
No. Yeah, of course. Again, mine's not as pretty, but hopefully it still serves the purpose.
Print screen complete.
Well, I've saved it, so I can also, a lot of these things I add to the website as well. Go back to the first hormonal control slide. Yeah.
Like detail.
Oh, the words?
Yeah, thank you.
What I can do. This one?
Yes.
Again, You are welcome to take the time to write these down. But remember, I also have these slides on for you on Canvas, so you have that as well. So don't feel the pressure to write this all down. You can have those to look at. You can print them out. I've had some students that they have the iPad sitting next to them with the notes, and then that way you can, you know, write on it as you're doing it or whatever. So that works too. All right, excellent. So this is our hormonal control of the ovarian cycle. Any questions on this? Did you get what you needed from this page?
Yes, thank you.
Excellent. Again, here is the pretty picture from your textbook that kind of shows these same things as well, triggering the release and all the things that go along with that. We've talked about all of that. But like I said, I think this is the one that I think is useful because, again, it shows how the luteinizing hormone and the follicle stimulating hormone of the anterior pituitary drive those processes that are taking place in the ovaries. Well, there you go. Well, at least you learned eventually. So there you go. Excellent. All right. So we now understand this complicated relationship between the anterior pituitary and the ovaries and the hormones made from the ovaries. But as we've also talked about, there is a fourth part of this. These hormones of the ovaries, not only do they influence the anterior pituitary and the hypothalamus, but these estrogens and progestins also influence the uterus. And so the last part that we need to add to all of this cycling is a discussion of what's going on in the uterus. Of course, to do that, we have to start talking about the female's reproductive tract. Much as we left the gonad in the male and then went into the tract, we need to do the same thing for the female. So we've talked about what happens in the ovary. Let's talk about what happens to that. And as you can see, there's a cute one of it right here, that ovulated egg. When that egg is ovulated, the goal is to hopefully get it into the female's reproductive tract. However, as we've talked about, this uterine tube, or what is also known as the fallopian tube, or also known as the oviduct, all of those are acceptable terms, is not directly connected to the ovary. So the hope is to get the egg into there, but it's not guaranteed to happen. The uterine tube is also, if fertilization is going to take place, it is where that fertilization is going to take place. Notice there's an enlarged region to it right here, about a third of the way down, known as the ampulla. And that ampulla is typically where the fertilization will take place if it occurs. It is connected directly to the uterus. So as we see here on the uterus, and let's use some color that stands out, there is this narrow lateral region to the uterus known as the isthmus, which is where the uterine tube connects to it. But as we've talked about, it doesn't directly connect to the ovary. It does drape over the ovaries. There's some specializations that we'll talk about, but it does not directly connect to it. All right. As we mentioned, let's look at some of those specializations, starting first, as we talked about, with this enlarged region known as the ampulla. The ampulla then feeds into a funnel-shaped region. This funnel-shaped region is known as the infundibulum. It is kind of like the palm of the hand, and it has finger-like extensions that come off of it. And those finger-like extensions that come off of it are what are known as the fimbria. These fimbria move in a wave-like motion over the surface of the ovary. The goal of this is to produce small currents in the interstitial fluid, well, not interstitial fluid, really the peritoneal fluid, the serous fluid of the peritoneal cavity, to help to draw the egg into it. There are some anatomists who believe this wave-like motion of the fimbria over the surface of the ovary may also be one of the factors that triggers the rupturing of that follicle. Remember, we saw how that one follicle bulged out the edge of the ovary. So it may be the contact of the fimbria with that that helps to trigger ovulation when it occurs. And its job is to draw that oocyte, secondary oocyte, frozen in metaphase 2, into the infundibulum, where it is then moved to the ampulla. And I do mean moved, right? Again, this does not have a flagellum. This does not propel itself. So the fimbria are producing currents in the fluid, and those currents in the fluid help to draw the oocyte in. And here in the infundibulum, as I mentioned, we have a ciliated tissue. So of course, here in the infundibulum, what would that ciliated tissue be? It would be a ciliated
Pseudostratified columnar epithelial tissue.
exactly, a ciliated simple columnar epithelial tissue. Wait, what? Yeah. Remember how way back when we were talking about the male reproductive system, we talked about how in the epididymis we find a unique tissue that we haven't found anywhere else in the body, and that was a ciliated pseudostratified columnar epithelial tissue that didn't have motile cilia? Well, here in the female's uterine tube, we find a tissue we haven't found anywhere else in the body. And in this case, it is actually a simple columnar epithelial tissue, not with microvilli, but with actual cilia on their surface. And their goal is to grab onto and help to move that egg down the uterine tube. So they're going to be able to move that egg, project it along its path. Now, it's not a particularly fast process. These cilia move at a rate where it takes about 5 to 7 days for that egg to reach the uterus. How long is that egg viable for after ovulation?
48 hours.
No, actually closer to 24, right? It's actually closer to 24 hours that it's going to be viable for. So notice, if that egg is released and not fertilized, is it ever making it to the uterus?
Doesn't it have to?
If it's not fertilized.
Even so.
Nope. If it's not fertilized, then basically it is going to degenerate, break down, and be reabsorbed just basically here in the uterine tube. Menstruation is not the expulsion of an egg that hasn't been used. The egg, if it's not fertilized, never makes it to the uterus. The only way an egg would make it to the uterus is if it gets fertilized. If it gets fertilized, then it's maintained, then it makes it to the uterus. But if it's not fertilized, it's just going to be broken down, degenerate, and reabsorbed here in the uterine tube. So it only gets to see the uterus if it gets fertilized. Another big difference between the males, right? Obviously, a sperm gets to see the entire reproductive tract of the male, regardless of whether it is successful in fertilizing an egg or not. But obviously, the egg only gets to the uterus if it's fertilized. All right, excellent. So like I said, oocyte viable for about 24 hours. Says 3 to 4, but really it's closer to 5 to 7 to move it towards the uterine tube. Down the uterine tube to the uterus. So again, if it is not fertilized, it's not going to make it to the uterus.
So I have a quick question.
Yes.
Does the fertilization occur then in the ampulla, like on this diagram? Where would
Yes.
fertilization occur?
Yeah, exactly. So, and again, we'll talk about this on Monday, but you absolutely have the right idea. The goal for the female is to ovulate the egg and get it into the uterine tube into about the ampulla. The goal for the male is to present the sperm to the vaginal canal and have enough of the sperm make it up through the cervix into the uterus, down the correct uterine tube, all the way to those eggs, with a number close to somewhere around several hundred, so that they can beat the heck out of those defenses and one of them can get inside and fertilize it. So yeah, when fertilization takes place, if fertilization takes place, it almost always takes place in the ampulla. All right, questions on that? All right, excellent. So let's talk about the uterus. Uterus is a hollow organ, muscular lumen between the bladder and the rectum. Again, remember the reproductive tract is separate from the digestive tract, is separate from the urinary tract in the female. And of course, the function of the uterus is to receive, to retain, and to provide nourishment for that fertilized egg. So every month it gets its hopes up, gets itself ready, anticipating that event to occur, hoping that it occurs. And does it occur every month? Well, hopefully not. Hopefully not every month, right? I know Allison likes having kids, but you don't want to have one every month for now to the end of time, right? Absolutely. So, but occasionally it will happen and will occur. When we look at the anatomy of the uterus, like the anatomy of many structures we've talked about in this class, there are three primary walls to it, or primary layers to it, I guess would be more appropriate to say. The first is the innermost, the endometrium. Endometrium is the thin inner lining. As we'll talk about, it has two distinct layers to it, to that endometrium, that play an important role in the uterine cycle. This is what allows and readies itself for implantation, thickens, enlarges, glandularizes, vascularizes, so that it can house that fertilized egg. And if that fertilized egg doesn't come down the pipe, what happens? What happens to that?
Sheds it.
Yeah, we shed and it sloughs off and sheds, then forming the menses for the female's menstruation. Absolutely. And the process starts anew. Deep to the endometrium is the myometrium. What type of tissue is the myometrium? Well, it's got the term myo in it, so that should be one of the dead giveaways.
Smooth muscle.
Smooth muscle, absolutely, excellent, right? It is smooth muscle. It is not something you can voluntarily do, right? Is anyone able to voluntarily, consciously contract their uterus right now? No, even during parturition, during labor and delivery of that baby, it is not the uterus that the female is contracting. She's contracting her abdominal muscles, her levator ani muscles, all of those things to help to increase the pressure to force it out. The uterus does absolutely contract on its own, right? Forming those contractions. They got that cool little thing you can put on and measure, watch the contractions as they occur, but obviously that isn't something that you are consciously controlling. And it is indeed an intraperitoneal organ, as we saw. So, of course, the outer surface of it, what we call the perimetrium, is also just simply the visceral peritoneum. So we have that visceral peritoneum lining the outer surface of this intraperitoneal organ. Did I not talk about the anatomy of this? Hold on. Was I supposed to do that already, or are we doing that later? No, we missed that. All right, let's go back. Let's go all the way back. Here, I like this picture. Excellent. We talked about the functions. We didn't talk about the anatomy, although we talked a teeny bit about it. We know that there are these two narrow lateral regions known as the isthmus, where it connects to the uterine tube. There is also a narrow distal region known as the cervix. The head of the cervix, as you can see, actually extends out into the vaginal canal, so that its cervix extends out into that space. And in fact, we'll talk about this again when we get to the vaginal canal, but we can talk about it now. There are these spaces along the lateral aspect of the head of the cervix within it, known as the fornix. So these indentations around the edge of the cervix is a space known as the fornix, right? In ancient times, and by ancient times, I mean in the 80s, there was a very popular contraceptive known as a diaphragm. And a diaphragm, when used correctly, was 100% successful at preventing pregnancy. Basically, what you would do is you would go to your gynecologist. Your gynecologist would reach into your vaginal canal and measure the size of your fornix. And you would get a metal ring that was produced specifically for your fornix that had a rubber diaphragm over the top of it. When you were feeling amorous, basically you would take that structure, insert it into your vaginal canal, tightly fitting that ring around the head of the cervix, and then the diaphragm would sit over the top. If you were feeling particularly protective, you could put a little spermicide inside of that and put it on top. And like I said, when used correctly, it was 100% effective at stopping pregnancy. Because basically what our cervix has is it's a thickening of the muscular wall in the cervical head with a very narrow cervical canal that passes through that. And this is where the sperm has to go to get in. So if you had this rubber diaphragm, especially if you put a spermicide inside of it, the sperm could not get in. If on the off chance some sperm got in, they ran into the spermicide and they would be killed. And it was incredibly effective. So if that was so successful and so popular in the 80s, why the heck aren't we using it today?
Infection.
Absolutely, right? Okay, aside from the fact that it isn't the most amorous thing to right before you make love to take this little piece of rubber and insert it into your own vaginal canal. Notice I also said it has to be used properly. If it's not properly set onto the cervix, that could be an issue. Not surprisingly, some women were embarrassed about having to go to their gynecologist to be measured for this, so they would just borrow their friends, which might not be the right shape for theirs. I'm sure they washed them first. I saw your face, but still, you're right there. If it doesn't fit properly, then it doesn't form the seal and student copy to get in. So obviously there's all the complications that go along with that, but Daniel's 100% right. While this is 100% effective against pregnancy, it does absolutely nothing for sexually transmitted diseases. And the end of the 70s, the early 80s is when, sexually transmitted diseases increased dramatically. And so obviously something like a condom, which can protect from both pregnancy and sexually transmitted diseases, it can become much more common. Excellent. So we did that. Two more things. The bulk of the uterus is, of course, the body. And then the superior surface of it is this enlargement known as the fundus. One of the interesting things about the fundus is as the baby grows and the uterus expands, the fundus becomes very, very prominent and can actually be palpated by you and your doctor. And in fact, one of the interesting things about the uterus is uterus growth is very, very standard in its growth during pregnancy. So what the doctor can actually do is they can actually take a ruler or a tape measure from the pubic symphysis, palpate the top of the fundus, measure up to the top of the fundus, and that distance that distance from the pubic symphysis to the top of the fundus actually gives them an almost to the day accuracy of how far along you are in your process. One of the first things they do is they tell you, oh, you're 3 weeks and 7 days, or I guess that would be 4 weeks. You're 3 weeks and 6 days, pregnant, 3 weeks and 6 days pregnant. They're able to get that fairly precise. Yeah, I'm going to go ahead and silence the as well. I appreciate that kids are appropriate for this conversation. Let's turn that down. That fairly precise measurement can actually give you a fairly accurate description of how far along in the pregnancy you are. All right, so now we've talked a little bit about the microscopic anatomy, and now we've talked about the gross anatomy. So we've done that as well. We did all of that. Excellent. As I mentioned, the endometrium has 2 primary layers. These are the ones that play a role in our uterine cycle. The first is the stratum functionalis. This is the superficial layer, or what is also known as the functional layer. This is the one that is sensitive to the ovarian hormones. And so it grows and expands and responds to those ovarian hormones. And so this is the one that when those ovarian hormone levels drop, this is the one that is shed during menses. Deep to that, and its name kind of tells you that, is the stratum basalis, or the basal layer. This basal layer is less sensitive to those ovarian hormones. And so therefore, by forming the base, allows for the regrowth of that functional layer each month. So when that functional layer is shed, we're able to grow it back again and keep the process going. This also contains the base of many of the uterine glands that are going to play an important role in producing what they call the uterine milk, which plays an important role in helping to maintain that fertilized egg as it is getting ready to implant. All righty, we need to talk then about the uterine cycle and the anatomy and how it changes as we go through this. But I think this is a good stopping point. So let's go ahead and take our first break now. We'll take a 15-minute break. So we will restart at 9:20. And at 9:20, we will finish the rest of our discussion, look at the histology of the endometrium, and then talk about the function of it and our last cycle, our uterine cycle. And I'll start the recording at that time. So any questions before we take our first break? All righty, excellent. I will see you guys in 15 minutes. Get started. Okay, so we were just talking about the layers of the endometrium, and we've done it with the pretty words. Let's take a chance to do it with the pretty pictures. Here we see an illustration of some light microscopy showing this process. Notice we can see some fairly good distinctions between the area of the smooth muscle with its irregular banding. We can see this darker, more distinct layer, which is the stratum basalis, where again, we have the base of many of the glands that are located. It's typically darker in color. And the functional layer that as it regrows tends to have more of a lighter coloration as it is expanding and growing outward. Now, not surprisingly, these are going to undergo some dramatic changes during the process of the uterine cycle. And those changes, not surprisingly, are due to a fairly elaborate vascularization. Now, unlike the kidneys, I'm not going to make you learn the entire pathway and everything that is associated with it. Oh, it's pretty straightforward. The uterus, as we know, is fed off of the internal iliac artery. So the internal iliac, remember, feeds basically most of the organs in the pelvic bowl. Coming off of that is the uterine artery, which feeds into an arcuate artery, which feeds into a radial artery. And again, I'm not going to make you learn those pathways, but as we enter into the wall of the uterus, what I want you to see is that there are two main early branches that are found here in the uterine wall. The first are these relatively short blood vessels known as the straight arteries. They're relatively short, and as the name indicates, they're relatively straight. But notice adjacent to it is this highly convoluted, very twisted blood vessel that becomes much longer and much more elaborate in its branching. And this tightly coiled blood vessel is what is known as the spiral artery, or is also referred to as the coiled artery. So these are the two blood vessels that really make a big difference in the function of this. And the primary reason for it is, as it turns out, the straight artery, based on its shape, is unresponsive to ovarian hormone levels. Let's make this a little smaller so it fits in the space. Whereas our spiral arteries are very sensitive to the ovarian hormone levels. And it is this difference in their sensitivities that lead to the difference in growth and the shedding, ultimate shedding and recycling of this in our uterine cycle. So it's these two very important blood vessels, the straight artery and the coiled artery, that lead to these phases that occur. So there you go, straight arteries, spiral arteries. And it is the spiral arteries that are sensitive to those hormones, and those are the ones that degenerate and regenerate due to those changes in hormones. All right. So let's talk about the uterine cycle. The uterine cycle is changes to the endometrial lining. And as we know, this occurs in relation to the ovarian cycle. So if we think of the events associated with the ovarian cycle, and I guess we can do this on the board. This is a little bit more simplistic, but we can do this here. As we know, in the ovaries, it starts with low levels of estrogen and progestins. Oops, why did that not write? Where'd that go? Excellent. So that is our starting point. We start with low levels of estrogen and progestins. And then from that, that's starting day one. How do our hormone levels change moving forward from day one?
They began to increase.
Both estrogens and progestin levels increase?
Just estrogens.
No, exactly. So what happens next then is we get an increase in estrogen levels. That continues till about when?
14.
Yeah, day 14. At day 14, something special happens. What's that special thing that happens at day 14?
Ovulation.
Ovulation, excellent, occurs. And as a result of that, we get the formation of the corpus luteum. And how does that formation of the corpus luteum change the hormone levels?
Causes an increase in progestins.
Excellent. We get a massive production of progestins. but also estrogens as well, just not quite to the same level. However, what happens to those levels? Yeah, they plummet, they go down until eventually we have low levels of estrogens and progestins, which is where we started. So this is how our ovarian hormones essentially fluctuate over the 28-day cycle. So these changes in hormones lead to changes in events in what is going on with our uterus. So in our uterus, we are going to see changes that are occurring associated with these changes in hormones. Now, starting day one, as we mentioned, we have our first stage, that is the menses. This is when the menstruation lasts. And again, it varies from woman to woman, but on average, this lasts somewhere usually around 3 to 5 days. So from day one till about day 5, we have this menses. Menses occurs because the low levels of estrogen and progestin affect that spiral artery. Our spiral artery, which we said is sensitive to these hormone levels, when the hormone levels drops, that big coiled tube kind of twists and bends. And it's like a big coiled hose. And when you put a kink in a hose, what happens?
You increase the pressure but decrease the flow.
Exactly. As a result of that, the flow stops. Absolutely. So when that spiral artery, with those low levels of hormones, our spiral artery kinks. And as a result of that kinking, there is a loss of blood flow to the functional layer of the endometrium. And as a result of that, the functional layer breaks off and sloughs off and is released. Through the cervical canal, out to the vaginal canal. So we get the expulsion of tissue and some blood. I know I say some blood and I always get smirks from women when I say that, but actually the majority of the material that is released in the menses is the lining of the endometrium. Usually it's only a couple hundred milliliters of blood that is lost. And again, that's a good thing. We don't want major losses of blood occurring, and that kinking of the arteries helps to reduce the actual amount of blood that is actually lost in that process. So that is our menses. That leads to then the second stage of our uterine cycle. And the second stage of our uterine cycle is that growth, that regeneration of the layer. This is the proliferation stage. During this period of time, as estrogen levels increase, trigger the regrowth of the spiral arteries and the functional layer. So we start to get the regrowing of that layer, the reglowing of the glands and blood vessels, as we get that regeneration of that tissue. And this lasts again from about day 6 till about day 14, when ovulation occurs. And as you can see, this regrowth is triggered by the estrogen levels. But that brings us to our secretory stage. During the secretory stage, which is about day 15 through day 28, this process is driven by now the massive increase in progestins. It is now the progestins that are driving this. And remember, as we mentioned, those progestins are the warning bells that are going off that tell the female that pregnancy could be occurring any moment now. That egg could be fertilized, and we've got to get the uterus ready. So those progestins trigger a massive growth in tissue, in blood vessels, and especially in the glands. We get this massive glandularization. We'll look at this when we look at the histology of it, where we see these massive spiral glands that are very indicative of this stage, because that the uterus has to get ready for implantation. Now, remember, notice this is a 14-day process, because remember, as I mentioned, it could take that egg as long as a week to make it all the way to the uterus. And once it gets to the uterus, it doesn't implant right away. It could take another 3 days or so before it finally implants in the walls. So from the time of fertilization, it may be as long as 10 days before it is able to implant into the wall of the uterus. So in the meantime, the uterus has got to get ready. It's got to be producing that uterine milk. It's got to be big and massive and glandularized as it sits there waiting for that fertilized egg to come. But if the egg isn't fertilized, as we know, the corpus luteum goes away. And if the corpus luteum goes away, our estrogens and our progestins drop. And that leads to, once again, the kinking of the spiral arteries. And the whole process begins again. So there are these basically 3 main stages to the uterine cycle. I've done this really simply on the board, but let's look at the pretty pictures from your textbook. Again, these changes in the uterus occur because of the ovarian hormones, estrogen and progestins, primarily progesterone. It starts with the menstrual phase or menses, 1 to 5 days, where that functional layer is sloughed off. Again, less than a couple 100 milliliters of blood is lost to this. It's primarily tissue that is lost during this process, although there can be some variations. Typically after pregnancy, menses tends to be a little bit larger because, again, a uterus of a female who has never been pregnant is about the size and shape of a pear. Obviously, it has to expand to be able to accommodate a basketball. And while it shrinks back in size, it typically never gets fully back to the size that it was before. So because it's slightly larger, not surprisingly, it has a larger lining to it. And so menses can typically be larger after pregnancy occurs. Now, remember, in the ovaries, this is the time when our primordial follicles are developing into the primary and such like that. So we are starting to get an increase in estrogen production. And as that estrogen increases, that estrogen drives the regrowth of the uterine wall. Notice how small the uterine wall is here. This is a relatively low magnification, as we see. We can barely make out individual nuclei. But notice we are able to see all of the layers of the some of the myometrium, some of the basilar, and that small bit of functional layer. So from day 6 to 14, our proliferative phase or pre-ovulatory phase is when that estrogen drives the regrowth of our functional layer. We start to get some of the glands that are growing back into this, that are going to produce that mucus, that glycogen-rich mucus uterine milk that, like I said, is going to help to sustain that egg. Our spiral arteries regrow, and we start to rebuild that layer. However, then we hit ovulation. And when ovulation occurs, the growth goes into overdrive. Notice here is even a lower magnification view. I can't distinguish individual, I can barely distinguish individual nuclei of the individual cells. And I think that's more just hope on my side that I can see that. And yet we can barely see the superficial edge of the functional layer, and it's completely filling the screen. Massive, massive growth of this functional layer. Look at the massive glandularization with these big, huge spiraled uterine glands that are filling this. This massive readiness, this massive growth, this massive glandularization, vascularization, all in anticipation of that fertilized egg. So this secretory stage, post-ovulatory stage, is this stage of massive growth, massive glandularization and vascularization as it gets ready for implantation. And again, it is progesterone that helps to drive this process. Some individuals who sometimes have difficulty not necessarily getting pregnant, they have no problem fertilizing the egg, but they may have difficulty maintaining that pregnancy. One of the things that can cause that is low levels of progesterone. So progesterone supplements are something that they can take after fertilization has occurred. You wouldn't want to take progesterone before fertilization occurs, because that's actually what the first birth control pills were. The first birth control pills were progesterone pills. Right? Basically, progesterone is the body's way of saying either we're getting ready for pregnant or we are pregnant. And if you're getting ready to be pregnant or are pregnant, do you want to be maturing new eggs? No. So women would take a progesterone pill for 3 weeks, tricking their body into thinking it was pregnant or it already released an egg, so it wouldn't start maturing another one. Of course, we believe that it was vitally important that the functional layer still be shed, so they would stop taking it for a week. And when they stopped taking it for a week, that would then allow menstruation to occur. And then they would start taking the pills again. So the very first birth control pills were basically 3 weeks worth of progesterone pills. Of course, women's schedules get busy and crazy, and they can't always be counted on to remember 7 days later to start taking the pills again. So what was the first big major change they made to the birth control pills?
Extended release.
No, not now. They did do things like that as well, but no, even something simpler than that.
Placebo.
Placebo.
Yeah, exactly. They added a 4th row of pills so that every day you were taking something, you remembered and you stayed on track. And of course, as you guys mentioned, it wasn't so much that a placebo and the fact that it was supposed to trick you into thinking you were getting some medicine or anything like that. But you're absolutely right. It was a placebo in the case that it was basically a sugar pill. It was a placeholder just so she could keep track of time and would do it that way. Now, yes, birth control pills have gotten much more oh, okay, cool. Excellent. Yeah. Much more sophisticated since then. But again, for some, that is still what they use as birth control. And yeah, exactly. With in vitro fertilization, you absolutely have the right idea. You want to start taking that progesterone to get the uterus ready prior to being transplanted and implanted in. So absolutely. So absolutely, that's a great example of that. So again, it can help with the maintenance of it, but doesn't help with the fertilization. Again, it needs to be patient because it could take as many as 10 days for that egg to implant. But if after 14 days we don't have a fertilized egg there, then we're not going to. At which point, our corpus luteum has degenerated, goes away, and the process continues again. So notice if we go back to this table that we have, we see once again that same cycle. We start with that menstruus that occurs for the first 5 days, the shedding of the functional layer, the regrowth, repair during the proliferative phase, the massive glandularization, vascularization, get ready for implantation during the secretory phase. But when estrogen and progesterone levels drop, boom, we shed the layer, and the whole process starts over again. So now we have truly synced all of these cycles, seen what's going on in the uterus, seen what happened in the ovary, seen what happened with the ovarian hormones, and seen what's happened with the anterior pituitary hormones. Questions on that? I have a question if you guys don't. How does this change when pregnancy occurs? How do we disrupt this so that this doesn't continue to happen?
You have an extended high level of the sex hormones.
You absolutely have the right idea. Our goal, if we are going to be pregnant and maintain that pregnancy, is we have to keep those high levels of estrogen and progestins. But you're right. That is definitely what we want to do. But we have the problem, and the problem is that the high level of those inhibit luteinizing hormone. And that's what, and the luteinizing hormone maintains the corpus luteum, which of course is responsible for producing those high levels. So how do we fix that? How do we resolve that? What happens?
You have more hormones in pregnancy, like
True. You're absolutely right. What happens is we introduce a new hormone. Now you're right. During the course of pregnancy, there are many hormones that are present and involved in the process. But the one that is going to help us to maintain the pregnancy, stop the cycle, and keep the uterus intact is which one?
Progesterone?
No, progesterone is what we need, but we need to be able to maintain. The solution to this is we need to maintain the corpus luteum. We need to maintain the corpus luteum, and we need a different hormone to help us to do it. There you go, HCG, which is great while we're talking right now, but you're not going to get away with using that on an exam, are you? So what does HCG stand for?
Human chorionic gonadotropin.
Excellent. Human chorionic gonadotropin is produced by the zygote and the developing embryo. So that developing embryo, that zygote, produces human chorionic gonadotropin. And what human chorionic gonadotropin does is it actually maintains the corpus luteum. So now, even though luteinizing hormone levels continue to drop, our corpus luteum stays big and healthy. And since it stays big and healthy, progestin levels stay high, estrogen levels stay high, the uterine wall stays thick and full, and we can maintain the uterine wall and maintain that egg that can implant in it and be successful. Of course, as we learned, Hormones have a way of sneaking out into our filtrate in our kidneys. But we also know we have transporters that bring them back in. But we also know that transporters have a transport maximum. So if you get enough HCG in the body, some will be released in the urine. And why is that significant?
Pregnancy tests?
Exactly. Because one thing and one thing only produces human chorionic gonadotropin, a fertilized egg. So if you pee on a stick and that stick indicates that there is human chorionic gonadotropin in your urine, mazel tov, you are pregnant. All right. So that is how we disrupt the cycle. That is how we maintain the uterine wall. And that is how we're able to maintain and establish the pregnancy until about week 9. At week 9 is when the placenta forms, and then the placenta takes over for the corpus luteum, producing the estrogens, producing the progestins, producing all those other hormones that Allison mentioned that we'll talk about a little bit next week. All right. Questions on that?
I have been told by patients that men are taking HCG to deal with hormonal issues. Why? Why is that?
Okay, I'm so glad you asked this question. I have not heard of it as being taken for hormonal issues, but I have heard of instances of females who are not pregnant, and you are absolutely correct, males that are taking human chorionic gonadotropin, but they are taking it as a weight loss supplement. One of the things we just finished talking about is, remember, as we mentioned, a female, when pregnant, is basically a baby oven with an increased metabolism. They need to have that increased metabolism. They need to, their body temperature goes up, their metabolism goes up, they become better efficient at converting lipids into energy as opposed to sugars. When my wife was pregnant, her favorite place to go in the whole wide world was the Cheesecake Factory. Why did she like to go to the Cheesecake Factory?
It's cold.
Exactly. Yes, there's cheesecake there, but more importantly, she was pregnant during the summer, and my little was born in July. So the one thing about the Cheesecake Factory, even more important than the cheesecake is there, is they keep it at about 12 degrees Celsius, right? It is, or actually, probably 12 degrees Fahrenheit. It is below freezing. So I'd be in there shivering, and she was happy as a clam. So absolutely, it increases the metabolism, it increases your fat burning. And so, since everybody is looking for that miracle pill so that they can be gorgeous on the outside, we don't care what these hormones are doing to you on the inside. We have no idea what they're doing to you long-term on the inside. As we know, hormones have all sorts of complications, but as we also know, it's all about what you look like on the outside that matters. And so, of course, for a while there, luckily a brief period of time, it has gone down quite a bit. But for a while, it was one of the hot supplements that people were taking to help them with their weight loss. And I see there was a bunch of other comments that were being made. Breast milk for bodybuilders. I haven't heard that one. I don't know. I mean, obviously, breast milk has is very nutrient rich. Again, it's one of those things where babies have an incredibly high metabolism. So it has a lot of wonderful nutrients and resources and all those things. But I haven't heard of that one. That one's interesting. But the human chorionic gonadotropin,
So I watched this documentary about different weird, all kinds of different health things. I think it was called Unwell. I'll have to look it up to be sure. So I asked my friend who is a lactation consultant, why would anybody have breast milk, if they're not an infant? And the only thing she could think of is breast milk has so many different kinds of proteins in it that aren't found in anything else, that might have like some niche for stimulating muscle growth and different kinds of nutrient enrichment. That was the only thing that she could think of, but there's actually no real evidence for it to benefit bodybuilding.
From a theoretical standpoint, what you say absolutely makes sense. Obviously, when we are infants, our growth and metabolism is the highest it will ever be in our life. And if we can be sustained on milk as an infant during that huge metabolism and growth, then obviously it must have the things in there to help you with that massive metabolism growth. However, the only thing I would think in relation to that is if you think of the volume of milk the baby drinks compared to their size, and if you're a full-grown male, to think of how much breast milk you would need to drink to be able to have that same level and have it help would be, well, if nothing else, very expensive. I guess would be one way, but I mean, the amounts of it would be pretty intense. Benadryl. How interesting. Breast milk goes for $1 an ounce. Wow. All right, excellent. Well,
I found it up to $2.50 an ounce. We called it liquid gold.
This is quite the rabbit hole you guys have gone down on this. Excellent. Well, this is cool. Again, a lot of this stuff I haven't heard of, but I may get pregnant just so I can sell my breast milk. That sounds like a good plan. I may do that. Then I don't have to teach anymore. All right, excellent. Yes, science. All right, excellent. So that is our cycles. Again, we have these hormones here that we've talked about. Your book's got this great table that does a good job with all of that stuff. The last bit we need to talk about, how are we on time? All right, we went down a rabbit hole, but we're still really good on time. The last thing we need to talk about is the external genitalia of the female, starting with the last part of the ductwork system, the vagina of the female, and then its orifice, obviously, on the outside surface of the body. Again, the vagina is an elastic muscular tube that extends from the cervix to the exterior of the body. Again, behind the bladder and in front of the rectum. And the vagina has 3 functions. What are the 3 functions of the vagina?
Canal for birth.
Excellent, right? So it's got to be an outward passage for the baby. What
Inward
else?
passage for semen.
Yeah, it's the copulatory organ, so it receives the penis, absolutely. And well, if the baby doesn't come out, then what does come out?
Anger.
Stuffing.
Waste.
How about the menses? Right. Every month, the menses has to come out if the female's not pregnant. So 2 things can come out, either the menses, the shedding of that functional layer, or the baby coming out if they're pregnant. And then obviously it's the copulatory organ. If we look at the anatomy of this, I think we can cheat and do a quick simple drawing. So again, it is this muscular tube that connects to the outer surface of the female perineal region. it has a thick fold in the mucous membrane that extends about 3/4 of the way across the opening near the distal end, forming a structure called the hymen. Why is this structure important?
I thought it wasn't.
Well, if it's present, you can get more goats for your daughter when you're selling her to, you know, some guy to be married. But what it does actually serve an important function, and that is that, again, remember, the reproductive tract of the female is an opening to the internal environment of her body. And reproductively, she's not even viable for the first 13, 15 years of her life. So during that period of time, this is an exposed area to the internal environment of her world. And so this helps to provide additional protection. Obviously, it cannot be closed off entirely. Why can it not be closed off entirely?
Menses.
Yeah, because when menses starts, it needs to be able to be expulsed. And as we said, it could take a year before she becomes consistent with her schedule and can become fertile as a result of that. So obviously the menses has to be able to be expulsed, but for the most part, we need that protection as we talked about. So that hymen provides that protection. The hymen, again, is a well-vascularized, well-innervated fold in the mucous membrane. So typically upon penetration, it ruptures. Now that penetration can be a penis, but it also can be a tampon or something like that if not inserted properly or carefully. However, the consistency of the hymen can vary dramatically. For some women, it's much more flimsy. So vigorous physical activity, horseback riding, even running, riding bikes, things along those lines can actually cause it to rupture. And in some individuals, it's actually thick enough that trying to rupture it can be so painful that it actually has to be surgically removed before insertion can take place. All right. As we mentioned, it surrounds the head of the cervix. So again, that head of the cervix extends into it. As we mentioned, the cervix has a narrow canal, that cervical canal through it. And within that cervical canal is a mucus plug. This mucus plug, again, helps to provide protection, limiting the movement of pathogens and other materials into the uterus and into the uterine tubes and into the abdominal pelvic cavity. One of the things that happens with the hormones involved in ovulation, those hormones involved with ovulation, like the luteinizing hormone and other hormones, actually cause a thinning of this mucus at that time, making it actually easier for the sperm to be able to penetrate through that mucus plug and be able to get to the egg to be able to fertilize it. So it does thin, becomes more watery around ovulation. As we mentioned, we have that fornix, the area around the head of the cervix for that there. Again, like many of the organs we've talked about, it is going to have an epithelial tissue, a membrane that lines it. And what kind of membrane lines the vaginal canal?
Mucosa.
Yeah, it's a mucous membrane or a mucosa. Excellent. And like all mucous membranes, we know it is comprised of an epithelial tissue on top of a connective tissue. What epithelial tissue lines the mucous membrane of our vaginal canal?
Non-keratinized, stratified squamous epithelial tissue.
Exactly. Excellent, right? Again, this is an opening to the outside world that we need to protect ourselves from. Reproduction, when done properly, should be vigorous. So again, this needs to provide protection from the friction that is produced via that. The connective tissue, what kind of connective tissue, of course, would it be? Come on, what are you supposed to guess when you don't know?
Areolar.
There you go. And of course, actually I have room, I'll do it up here. Based on location, an areolar connective tissue that's part of a mucous membrane we call a
Lamina propria.
excellent. Oops. Excellent. Notice as I've kind of drawn here, there are rugae that line the inner walls of the vaginal canal. Why are those rugae important?
They increase surface area?
Okay, it's true. Why would that be important to increase surface area?
Allow for stretch during birth.
So absolutely, one of the things that it's going to do is allow it to accommodate to pass that basketball that we talked about out during pregnancy. But let's go back to that surface area. What do you get with an increased surface area?
Increase absorption.
True, although should we be absorbing necessarily a lot of stuff in here?
Secretions.
We will talk about secretions in just a minute. It isn't necessarily involved in secretions, although that is another good guess. In fact, the walls of the vagina actually aren't glandularized. There aren't any secretions that are actually produced by the wall of the vaginal canal. With an increased surface area, you get increased contact. An increased contact would produce increased friction. And why might that be useful? There you go. Allison's got it. Stimulation, right? It's ribbed for his pleasure. There you go. Exactly. Absolutely, right? Again, the goal of copulation is propagation of the species. So if we can help to facilitate that positive feedback process that is going to cause the ejaculation to occur, right? You can get back to your regular life much more quickly if the faster it is done, right? So again, from a biological standpoint, speed is a benefit. So again, the faster ejaculation occurs, the more rapidly propagation of the species can occur. Absolutely. So we have that. Of course, there is a second layer deep to the mucosa. And that second layer, of course, as we know, is going to be the muscularis. And of course, as we know, what type of muscle forms the muscularis?
Smooth muscle.
Exactly, it is smooth muscle. Remember, one of the things we talked about, there's smooth muscle in the uterus. There's smooth muscle in the vaginal canal, and they're producing minor peristaltic waves. Remember, those minor peristaltic waves are going to help to propel the menses or any harmful dust and debris that gets into the vaginal canal out, leading to a little bit of discharge that can be released from the vaginal canal that way. And again, is anybody here able to voluntarily contract their vagina? No? Yes? Allison's smiling a lot. Absolutely. No, turns out no. I know that, again, during intercourse, it is possible for you to manipulate and modify the tension on the penis when it is in the vaginal canal. But what you have to remember is that your vaginal canal is surrounded by the levator ani muscle. And that levator ani muscle that surrounds the vaginal canal is how you are able to increase the tension on the penis during copulation. So you're not actually contracting the vaginal canal, you're actually contracting the levator ani muscle, which retracts and squeezes the vaginal canal. So it is actually that skeletal muscle of the levator ani muscle and not actually the smooth muscle of the vaginal canal that is contracting in those cases. All right, excellent. So I think my drawing has hopefully scarred you for life, but let's go ahead and talk some more about this again. Hymen, very vascularized, we talked about that. Here we see the picture. I'll move this over here so it's out of the way. We can again see that vaginal canal. See that again, there are going to be three layers, our mucosa, that non-keratinized stratified squamous, lined with the rugae that we've talked about. Our muscularis, which we now know is our smooth muscle. And again, the vaginal canal is not retroperitoneal. Remember, it's not one of our sad puckers, but it is under the peritoneal cavity. And because it is under the peritoneal cavity, it is not lined on the outer surface by a serosa. Instead, it is anchored to the surrounding tissue by an adventitia. This adventitia has a thick fibroelastic layer to it that, again, is going to allow that stretch and that expansion for the release of the baby, the expulsion of the baby. Excellent. So, as I mentioned, oh, actually, I guess we can go back to the picture for this. The mucosa does not contain any glands itself. The glands that produce the secretions for the vaginal canal are actually located within the head of the cervix. So the head of the cervix is what contains the glands, and it is the cervix that releases a very glycogen-rich mucus secretion. All right? Why?
Ease of penetration.
Excellent. So part of it is going to be for lubrication, and indeed, secretion of this will increase upon arousal. But it's actually releasing this all of the time. Absolutely correct, it is protection. Part of it is obviously the mucus, which can capture the dust and debris that we've talked about. But as we also talked about, this is open to the outside world. And so not surprisingly, there is a massive bacterial colony in the vaginal canal. Right? Does that mean that every woman should be running to the bathroom to grab their bottles of, what was it, Summer's Eve or whatever it was, so that they can rinse out all that horrible, horrible bacteria that is in that location? Isn't that what the stuff was called? Was it Summer's Eve? Is that that douche that used to have the commercials all the time? Yeah, excellent. Is that what they should all be running and doing? No, of course not, because these are, of course, resident bacteria. And what do we know about resident bacteria?
They're supposed to be there.
They're supposed to be there. They're helpful. They are both benign in that they don't hurt the female. They outcompete harmful bacteria, but bacteria just happen to love glucose. However, when bacteria break down glucose, what method do they use to break down glucose?
Fermentation, generally mixed acid fermentation.
They use fermentation, right? Which, of course, as we know, is anaerobic. And when you break down glucose anaerobically, what do you get as a result of that?
Alcohol, acid.
Lactic acid. As I mentioned once before, the vagina is a hostile environment. It has this acid mantle that helps to protect it because this is an opening to the internal side of the body. Vitally, vitally important for the function of the female, for the health of the female. Right, this acid mantle that is going to help to provide that protection to this opening. Now, what's interesting about this is that the vagina becomes more hostile with age. And these things are incredibly fun to say, but it is absolutely true. What's interesting is in adolescence, the vaginal canal can actually be more basic. And then as we age, it becomes more acidic. There may be two potential implications to this. One, urinary tract infections, reproductive tract infections, sexually transmitted diseases, those types of things, females are typically more susceptible at a younger age than they are at an older age. Much more common when they're younger than they are when they're older. And as we know, pretty much two teenagers just have to look at each other to get pregnant, right? Remember, one of the things that we talked about is that acid slows the swimming of the sperm. It is harmful to the sperm. So in an adolescent, when the vaginal canal is more basic, more of the sperm are able to swim more quickly. More of them are able to get into the uterus. More of them are able to get to the uterine tube, and it can dramatically increase the likelihood of pregnancy. Right? You hear plenty of stories of 30-year-olds going through all these issues and problems trying to get pregnant. But you also hear plenty of instances of two teenagers who just look at each other, right? And she's knocked up. So there can be implications from that as well. Again, the hymen, the acid mantle, all of these things, again, it's fun to say these things and to joke about these things, but it is vitally important because I can't emphasize it enough how this is an open system to the female, open to the abdominal pelvic cavity. So sexually transmitted diseases are much more dangerous in females than they are in males. All right. So again, there we go. Produces the acid minal, alkaline in adolescence, and that is the anatomy of the vagina. All right. Excellent. Questions on that? All right. Now, and again, this is the one nice thing about being online. When we're online, I don't have to look you in the eyes when we're talking about this, because here we get to some of the bad stuff we need to talk about. Absolutely. And that is the external genitalia, right? Even today, research on sexual reproduction, and especially female sexual reproduction is not only frowned upon, but it is almost taboo in many ways. And it has kind of always been that way. When we look at the anatomy, when we look at the terminology, right? The term itself, vagina. What does the term vagina come from? Anybody know?
Shame.
No, although we'll get to that one in just a second. Sheath, like a sheath for a sword, right? The external genitalia are referred to as the vulva, but a more antiquated term for this is pudendum, this external genitalia. And you are absolutely correct. Pudendum comes from the root for the word for shameful, right? We were talking before about that hymen and how, again, in, more medieval times, or that doesn't even, not even medieval times, in other cultures, in other religions, in other societies, a female is prized for having her hymen intact. I had a Ethiopian student 4 or 5 years ago who was actually, no, I guess, wow, 6 or 7 years ago now. She's already graduated med school. I got to actually go to her pinning. It was a great experience. Her mother was able to get her to a convent in Ethiopia, and she was able to flee the country from that. And there were women in her town that the males would sew up the vaginal canal when the woman, just before the woman reached puberty, as part of her maturation process. And then it was the honor of the male that she was given to for the wedding to be able to cut those strings open and be able to then have access to it. Genitalia mutilation is something that still takes place in females in many countries. Again, it is a horrible thing that is occurring. And again, because, and even here in America, right, we all appreciate and understand the danger of the vagina, right? Women can't be trusted around men. because they will force men to do things that men shouldn't do. It's not the men's fault, it's that woman for luring them on. God forbid she shave her legs, right? Or wear a tight sweater or something like that. Men can't be expected to control themselves around such sexuality. So again, it's truly repugnant and ridiculous. But let's talk about this from a biological standpoint and certainly understand the anatomy of this. One of the prominent regions that again grows during puberty. During puberty, there is a fat pad that basically sits on top of the pubic symphysis. Again, one of the things we talked about is how having an appropriate amount of adipose is one of the ways that the female body tells the hypothalamus that it's ready to be pregnant. We didn't talk about it at the time. We probably should have, but we were talking before about some of those extreme athletes, right? Individuals who just for the heck of it over a weekend run 240 miles, right? All in a 48-hour period of time. And some of these extreme athletes, these runners who get down to a 0.5% body fat, what can often happen to these women when they get to that kind of extreme condition?
Stop menstruating?
Yeah, they can stop menstruating. And the reason they stop menstruating is because they don't have enough adipose to produce enough leptin to maintain that cycle. So not surprisingly, this fat pad over the pubic symphysis enlarges at puberty, increases in size. Again, that swelling of the mons pubis, which is this region, is an indication of virility. And this is also the area where the pubic hair starts to grow as well. Notice also that there are two folds in the tissue in this area as well. The labia majora are the outer folds of the skin and are continuous with the skin. They contain the keratinized stratified squamous epithelial tissue. They can have hair going on them as we see here. These are the ones that also inside have the erectile tissue that will enlarge and swell upon arousal. Internal to that is the labia minora. The labia minora are a only slightly keratinized stratified squamous epithelial tissue. They are much more delicate, much more sensitive. They are hairless folds of skin. And they basically surround the openings, and there are indeed 4 openings that we will see that are housed within this space that we call the vestibule. So this vestibule is housed by the labia minora, where are not 1, not 2, but 4 different openings can be found. Both males and females have a region that we call the peritoneum. And here we see, we'll get to that in a second. So we can see this peritoneum here basically goes from the pubic symphysis to the coccyx to the ischial tuberosities. It is divided basically into 2 triangles, the urogenital triangle and the anal triangle. So we can see that with that there. But what this illustration shows nicely, although again, we have a little bit of artistic license going on here, there are 4 main openings that are found within the vestibule. So let's actually very simplistically draw this. So here is our vestibule. And in the vestibule, we have, actually, let me move this over here to the side, because then I can do this. As we just finished talking about, we obviously have the largest opening, which is the vaginal canal. We just finished talking about the vaginal canal. So the vaginal canal, of course, comes to the external surface of the body. We also have, as we've talked about, the smaller opening of, oops, that's not a color, the urethra. Obviously, these are not drawn to scale, but that's okay. We get the idea. The urethra, of course, connects to the bladder and is anterior to the vaginal canal, because again, as we've talked about in females, the urinary system and reproductive system share different pathways. But I also said that there were 4 openings. The other 2 smaller openings are the small openings that are posterior and lateral to the vaginal canal. These openings are the openings for 2 of the accessory glands found in females, and these accessory glands are known as the greater vestibular glands. These glands become active on arousal. They produce a thick, mucousy, alkaline, let's say it that way, a mucousy secretion. And what do you think the function of this thick alkaline mucus secretion would be?
To make the vagina more hospitable.
Yeah, exactly. Again, it is the copulatory organ. We need to facilitate copulation, so it's going to provide lubrication to be able to do that. So we have those glands, remember, coming off the cervix. We have the cervical canal up here with those cervical glands. So cervical glands become more active, greater vestibular glands become more active, and they release those secretions upon arousal to both help to neutralize the acidity of the vaginal canal, make it a more hospitable environment, and also to facilitate copulation. Now, the reason I wanted to draw this, and I've drawn this way, is I want to go back to the picture from your textbook here. Notice here the picture from your textbook. We again see the vaginal canal, and then notice they have actually put the hymen in place there. We see the smaller openings to the orifices of those greater vestibular glands. And here we see the opening of the urethra. But if you notice, and I guess I'll use a highlighter so we can still see this. If you notice here at the base of the urethra, we have these 2 openings that they have drawn there. These are supposed to represent something that is known as the periurethral glands. Now, let's go back to our drawing here. These greater vestibular glands become active upon arousal, produce a thick alkaline mucus upon secretion. What does that sound an awful lot like in the boys?
The stuff secreted by the bulbourethral gland.
There you go. So these glands are actually homologous to the bulbourethral gland, or what we also call the Cowper's gland, right? So we have that there. Well, it turns out there is an additional gland, glands, plural, called the periurethral glands. These glands are located kind of embedded within the wall of the urogenital diaphragm. And they have a duct that actually feeds into the urethra. Now notice that sounds an awful lot like those bulbourethral glands as well, because our bulbourethral gland was kind of located in the urogenital diaphragm. It released its secretion into the urethra. So notice your textbook cheats a little bit by trying to show their openings as being here on the outside. They're truly not. They feed into the urethra. So then if this is the one that's homologous to the bulbourethral gland, then what's the deal with this periurethral gland? Right? What is the deal with this? Well, as it turns out, there's a couple more characteristics we can identify about the periurethral gland. First off, it produces secretions on orgasm. So not upon arousal, but on orgasm. Also, notice its location within the urogenital diaphragm. It is located basically between the urethra and the vaginal canal. And for some individuals, manipulation of this gland externally, like through the wall of the vaginal canal on the upper surface of the vaginal canal, can bring incredibly intense, pleasurable sensations. What does that sound an awful lot like?
The prostate.
Exactly. This is basically the female prostate. It is also what some people affectionately refer to as the G-spot. Right? For some individual women, just like for some males, as we talked about, the palpating of the prostate can cause an intensely pleasurable and intense orgasm. For some females, manipulation of this periurethral gland can produce the same type of intense experience. And in fact, for some women, the amount of secretion that is produced can be fairly significant. So many women, upon orgasm, get a sensation that they need to urinate because, as we know, as a secretion like urine or like these periurethral gland secretions enter the urethra, that can give a sensation of the needing to void. And some women actually can void during orgasm. That voiding of the urethra is not urine. It has been, studied chemically, and it contains substances very similar to the secretions of the prostate. So it is basically the female prostate, and it can become active upon orgasm, leading to the secretions from the periurethral gland, causing women to feel like they need to urinate, or may even cause some secretion, urine-like secretions to come out. But it's not urine. Just like males, upon orgasm, the internal urethral sphincter constricts. So a female cannot orgasm and urinate at the same time. Yes, there is, I'm sure that I'm well aware of the fact that there is an Urban Dictionary term for the release of this secretion upon orgasm, but that's not for me to say. All right. Excellent. So notice while we're here, we've identified two of our accessory glands, right? A female version of the prostate, a female version of the bulbourethral gland. Or really, it should be the other way around. From a biological standpoint, female is actually the default setting. It is the Y chromosome that actually changes an organism from the female version to the male version. So really, it should be the other way around. The periurethral gland, or the prostate, is the male version of the periurethral gland. The bulbourethral glands is the male version of the greater vestibular glands. However, when it comes to accessory glands, does female have something that is homologous to the seminal vesicles, the seminal glands? No. Remember, the seminal vesicle glands produce about 70% of the volume of our semen, and they're primarily involved in the activation and the turning on and the providing the energy so that the sperm can swim. So the girls really don't have anything homologous to that. So there is no homologous structure for the seminal vesicles. All right, excellent. So we come back here. We see that vestibule containing the orifices. Again, the urethra, which has those periurethral glands, also called the Skene glands, because I'm sure good old Bob Skene was the one who first described them. The vaginal orifice and the two openings of the greater vestibular glands. We already talked about the perineum, and also contained within the perineum at the anterior portion of the vestibule is the clitoris. The clitoris is homologous to the corpus cavernosum. Again, remember, the urethra does not pass through the vagina or any of those separate organs, so there is no erectile tissue that surrounds the urethra the way that the corpus spongiosum does in the male. But as we have talked about, a female does have erectile tissue. Now, from this view, we can also see that it has an enlarged head region known as the glands. However, if we peel most of this pesky woman away, there we go, we can see some more of the internal anatomy here. And as we look at the internal anatomy here, we can see that, again, it is very homologous to a penis. We have a glans, we have a body, and notice, like the corpus cavernosa of the male, it has these tapered tails known as the crura that help to stabilize it and anchor it in place against the pubic symphysis. As I mentioned, if we go back, again, there is a fold of skin that wraps around the anterior part of the vestibule that wraps around the glands, known as the prepuce. As we talked about with genital manipulation for females, often the clitoris and the prepuce can be removed, right? Why do they do that? Is it important for some religious, for health, for anything like that?
So women don't enjoy it.
Exactly, right? Because women are evil. We don't want them to be able to enjoy sex. So again, that genital manipulation, unfortunately, still takes place today. Absolutely. What is the function of the clitoris? I think you kind of hit it on the head already. Again, remember, the point of copulation is to propagate the species. And if you want to propagate the species, making it enjoyable makes it more likely that people are going to want to do it. It is also believed that the location of the clitoris, and as it becomes engorged, it can come in contact with the penis. And so that's manipulation of the penis can again help to stimulate the penis to help to encourage ejaculation to take place. Yes, indeed. Sadly, that is true, Daniel. Sadly, that is true. But notice also that the clitoris is not the only erectile tissue that is found in the region. So again, notice we see our 4 openings, greater vestibular glands, and then notice we can see the glands themselves inferior to the tissue coming out here, our vaginal canal, as we talked about. Those improperly labeled periurethral glands, openings to the orifice. But what I want to talk about are these 2 big enlargements of erectile tissue that sit inside of the labia majora. As I mentioned, the labia majora has these bulbs, and these bulbs are able to expand. I think I talk about this in the next slide. Yep, there you go. The bulbs of the vestibule also contains this erectile tissue that also becomes swollen during arousal, and again, serves 2 functions. Function 1 is again to help to maintain the penis within the vaginal canal. So by swelling the labia around the penis, it helps to maintain the penis in the vaginal canal during copulation. And then once ejaculation occurs, that swelling of the labia helps to keep the semen inside, because after all, we need to keep the semen inside so the sperm can get where they need to go. All right. Questions on that? All right. When it comes to female sexual function, it is actually very, very similar to males in that primarily it involves 2 key components. Again, we have our point and shoot. Remind me again what that means.
Erection and ejaculation.
Right, exactly. And more importantly, arousal is driven by what branch of the autonomic nervous system?
Parasympathetic.
Parasympathetic. Whereas orgasm is driven by sympathetic nervous system. So we have that similar to males. The other way it is similar to males is that it is going to be a combination, both arousal and orgasm is in a combination of both glandular activity and smooth muscle contractions. So arousal is a parasympathetic reflex. Right. In the exact same way, our parasympathetic nervous system releases nitric oxide. That nitric oxide dilates blood vessels. And that dilation of blood vessels leads to the engorgement of the clitoris and the bulbs. We also get an increase in glandular secretion upon arousal. And again, these are going to both be the cervical glands and the greater vestibular glands. Again, this helps to neutralize the acidity of the vaginal canal. This helps to provide lubrication for copulation to be able to take place. We also get contractions of smooth muscles. We will start minor contractions, minor peristaltic. Contractions of the vaginal canal. And these are actually a reverse peristalsis. Remember, as we talked about during normal life, the peristaltic contractions are expressing things out of the vaginal canal. In this case, the reverse peristalsis is going to help to encourage the semen to move up towards the cervix. So we get minor reverse peristaltic contractions, contractions of the smooth muscles of the areola upon arousal, which occurs in males as well. But you get the contraction of the nipples become erect as a result of that as well. Orgasm in females is also a positive feedback process. Continued manipulation, continued stimulation enhances the sensation, bigger electrical signals, which causes more sensation, bigger, and so on and so forth until orgasm occurs. And again, orgasm is going to trigger glandular activity and smooth muscle activity. Large peristaltic contractions of the vaginal wall and the uterus. And again, this is a reverse peristalsis to help to draw the semen up towards the uterine tubes. We get an increase in the glandular secretions of the cervical glands, of the greater vestibular glands, but upon orgasm, as we also talked about, you can get secretions of the periurethral gland that occurs as well. Now, while there are tremendous similarities in this process between males and females, there is also two big differences. What are the two big differences between this process in males and females?
Fertilization can occur without orgasm in females?
Yeah, exactly. The orgasm is not required for fertilization. Now, notice it does help. An orgasm in the female will produce those peristaltic contractions that can help to draw the sperm up towards up through the vagina, and up through the uterus. So it can help, but it is not required. And what's the other big difference? After orgasm, do females enter a period of detumescence? No, no refractory period. So for some women, it is possible to have multiple orgasms within a single encounter or manipulation. because they do not have a refractory period the same way that the males do. All right. Questions on that? All righty. Excellent. All right. That is everything I wanted to talk about for the female reproductive system. However, how are we on time? We are doing great on time. I want to do a brief introduction to this, but I'm going to save the rest of this for our discussion on Monday next week. But I want to talk a little bit about the development inheritance. Obviously, this is a huge chapter in your textbook with a tremendous amount of material. And as I mentioned, there are literally semester-long classes where you just talk about these things. So obviously, we are not going to be doing any service to any of this, but I do want to at least have a brief introduction to it. And for our purposes, we are going to focus on the very beginning of the process and the very end of the process. Now, as we also talked about, biology in general is like learning a new language. However, we also talked about anatomy and physiology and also genetics. It's even worse, with a massive vocabulary to it. So again, I want to make sure we have some understanding of some of the terminology that we're going to be using when we talk about these things. Starting first with a gestation period. A gestation period is basically counted from the last menses to the time of birth. Right? This is kind of like that new math they're teaching the kids these days in school, right? Because if you think about it, the way this works, when that egg is fertilized, it is technically the instant that egg is fertilized, it's 2 weeks old, right? Again, our counting, we can't necessarily know exactly when fertilization took place, so we count from the beginning of the last menses. As we know, ovulation occurs around day 14. It's good for about 24 hours. So when it gets fertilized, technically, that brand new fertilized zygote is considered to be 2 weeks old. So again, we're using some new Common Core math here when we're explaining these things. But from the menses to the time of birth is about 40 weeks. But anything after 36 is considered fully baked. Typically, this gestation period is divided into 3 trimesters. So again, the first trimester is typically when you have the most fluctuation in the hormones. So often those changes in hormones can be detrimental to the health of the mom. And so you get things like morning sickness and other types of issues that occur as a result of that. Prenatal period is basically everything up to the point of birth, but it's divided up into 2 main phases. First, when we have an embryo, which is the embryonic development, which is basically everything from fertilization up to about 9 weeks. And then the fetal development, which is basically everything from the 9 weeks to birth. And I think I mentioned it earlier, but I make a point of emphasizing it again. What is the big defining event that occurs that really separates embryonic development when we have an embryo to fetal development when we have a fetus? Does anybody remember what I said?
Development of the placenta.
Exactly. Basically, it is the development of the placenta. And that development of the placenta is what basically leads to that change, that distinction from being an embryo to being a fetus. All right, so at this point, that is when the placenta is functioning and is primarily responsible for all of the hormones involved in the gestation process. Of course, the neonatal period is basically the first month after birth. And of course, the field of study involving this pregnancy, labor, and the neonatal period is the field of obstetrics. Okay. Most obstetricians are also gynecologists. So again, they get to be full service female doctors, both when and when not pregnant. So again, mostly you have the field of OB-GYN. Right, so basically for the whole female health of her hoo-ha. All righty. I have daughters. I don't have a cutesy name for a penis, right? Anytime we talked about that, it was always bad. No, get away. So, but we did have a cutesy word for it. Yeah, because again, my daughter, when we were driving the car, she would get bored in the back seat. And so she would, she was 2. And so she'd be all, tell me something about the body. And so we would talk about, the lungs. We would talk about all of these kind of things. I will never forget it. It's my favorite memory in my entire life. I picked her up from her first day of school and asked her how it went today. And she said, for kindergarten, she said, oh, it was great. It was amazing. She's all, what are those purple things in your body? And I was all, purple things in your body? Like blood vessels? No, where is it? Everywhere. And so I'm racking my brain and trying to think what we had been looking at. And then I remembered we had been looking in the textbook, and in chapter 3 in the cells, right, the nucleus is purple. So it's all the cells. So yeah, I had so much fun. My cells are tired. So she, so she was always interested in it. And so it was always very fun, and so I was always very open and honest with her about all these things, but I couldn't have a 2-year-old saying vagina. Just so hoo-ha it was. So like I said, I have a cutesy word for that. I don't have a cutesy word for a penis. So sorry. Anyway, totally random, had nothing to do with anything. Exactly. There you go. Excellent. So as I mentioned, what we are going to focus on mostly is this stage from fertilization to implantation. So again, we've talked about ovulation, getting into the uterine tube, getting to the ampulla. We've talked a little about the sperm getting there. So we're going to talk about all the events that occur from the point of fertilization to the point that that fertilized egg implants itself into the wall of the uterus, because that goes along well with all the anatomy and the other things we've talked about. And then from there, we will rapidly fast forward 36 weeks until the end of the process when parturition takes place. And we'll talk about the events that lead to the labor and delivery as well. Now, this is 2 days before the exam. So again, I am going to be limiting the material that we're going to be talking about at this point when we're discussing these things. But I find that some students have some challenges with this, not because I think this information is necessarily harder, but again, as we talked about, there is some interesting vocabulary that goes along with this, right? You can be almost 100% certain. I have to say almost now, because if we were given this in the classroom, I know for a fact you would be spelling syncytiotrophoblast. But now I guarantee one of the questions in your test bank for the lab exam, you're going to have to spell syncytiotrophoblast. So obviously you need to know what the heck the syncytiotrophoblast is, what it does, and you have to be able to spell syncytiotrophoblast. So some of the alphabet soup terms associated with this can be a little bit challenging. But if you spend this weekend focusing on the lecture slides that you have, and then using that as a guide to help you with the textbook, because again, if you just look at the textbook, you'll be overwhelmed by the information. Use the lecture slides as a guide to help you to see what you should pay attention to. And like I said, primarily focus on these stages, and that will help you to be successful on Monday. All right. Believe it or not, that's all I have for you today. We're going to go ahead and finish a little bit early. So we'll finish early today. We'll finish early on Monday. Rather than pushing forward with this stuff, I want to be able to do it all at once. So again, it's not a ton of information, but it will be fun. We will go through that together, but I want to save it and do it all at once rather than separate it. So actually, this is all I have for today for the lecture. We are done with the lecture. However, the one last thing that I do need to do for us is, again, finish off our histology. So let's bring up, oops, wrong button. So you're not quite done yet, but we don't have too much histology yet. I think we've hit most of it. I think the main thing we have left is the uterus and the uterine tube. All righty. Here is a cross section through the uterine tube. Now, this is a pretty low magnification, and it's not even a very focused image. But what I liked about this is you can see it is a small enough structure that it's able to fit on a slide. But the real key, I think the real thing that really helps us to stand out and stick out and be obvious is its organization. Notice it has massive, massive folds of the mucous membrane that penetrate deep into the lumen of this structure. It isn't just a hollow tube. And if you think about it, that makes a lot of sense. If all we had was a hollow tube with those cilia lining the surface, there'd be a whole lot of space here in the middle for that egg to sit and never be able to go anywhere. So by having these huge folds in the mucous membrane, and they kind of look a little bit like the cerebellum. Maybe that's why I like this slide so much. It looks like the cerebellum. But these huge, massive folds of the mucous membrane in here basically mean that, and again, notice this gap is just more of an artifact from it being spread out. Anywhere that the egg is within this structure, it's going to be in contact with those cilia and be able to be propelled forward. So it forms a tight, compact space so that no matter where the egg is, it is going to be in contact with that oviduct and be able to move where it needs to go. Again, here's another great picture that shows this. And I think I have, yeah, this one's a little bit better. Here we got this one as well. And again, notice with this one as well, here we can more clearly see that it's a single layer of fairly uniform cells. We can see how the nuclei are lining up in a row. Because remember, what is forming the walls of this oviduct is a simple columnar epithelial tissue that has cilia on them. So this is the one place in the body that we've seen a simple columnar epithelial tissue with motile cilia. We've seen it with microvilli before, but this is the only place you're going to find it with cilia. All right. And I think that's it. I don't think there's a whole heck of a lot you need to know for the uterine tube or the oviduct. Questions on that? All right, let's take a look at a uterus then. Clearly, this is not a human uterus. You would not be able to get a human uterus on a single slide, but this is a rat uterus. But I think it's cool because you get to see the whole thing in here. So that's kind of cool. You see the lumen down the center. We can see the lighter colored area, which would be the functional layer. We can see the darker layer, which is the basal layer. And then we can see all of the big, huge muscular myometrium of that as well. And then, of course, the perimetrium, that visceral peritoneum on the outer surface. So here we see that basic anatomy of it. As we've talked about, your goal on this is not only to be able to recognize that it is the uterus, but the key for you is to be able to distinguish the two phases, right? Is this the proliferative phase or is this the secretory phase? So based on, let's go back to the previous one, which of our two phases do you think this one is? What do you think, proliferative or secretory? Yes, functional layer, stratum functionalis are both acceptable terms, yes. Basal layer, stratum basalis, I will accept both of those as well. All right, let's start easier. What stage do you think this is? Secretory or proliferative? All right, let's make it even easier. Proliferative phase, is that pre-ovulatory or post-ovulatory? Is it before ovulation or after ovulation? Maybe that's the problem. We're having trouble with terminology. Which one is it? Before or after?
Pre?
Yeah. So this is before ovulation occurs, whereas secretory is post-ovulatory. So proliferative, before ovulation takes place, we just need to rebuild the functional layer. After ovulation is when we need to get it ready for implantation with massive growth, massive vascularization, and massive glandularization, production of those massive spiral, huge spiral glands. So based on that, what do you think we're looking at here?
Secretory?
Yeah, these are those massive spiral glands we were talking about. All these spaces, all these pockets are these massive spiral glands. This is absolutely secretory. It is post-ovulatory. Massive spiral glands and a huge functional layer. Secretory. Massive glands, massive glandularization, right? Huge thickening of the wall. This is post-ovulatory, right? Whereas this one, not quite as much. This is near the end of the secretory. This is late secretory. We're starting to see some glands. We're starting to see some growths, but not nearly as full. And when we get back to ones like this one, or ones like this one, what do you think this layer, the timing of this one is? What stage is this one? Oops.
Menstrual?
No, again, we're not going to look at it menstrual. With menstrual, basically, first of all, menstrual is not on your list, so you don't have to worry about it that way. You should know that. But think about it, with menstrual, basically, all of this would be gone. All you would see is a very thin layer of the stratum basale, and basically nothing on top of it. So you have two choices. Is this pre-ovulatory or post-ovulatory?
Pre.
Pre, right?
So the follicular phase is the same as the proliferative.
Yes.
Okay.
Yeah. Because again, remember, that is when there's the follicle present. It is producing the estrogens, whereas the luteal phase, right, is when the corpus luteum is producing progestin, and that's when we're getting our secretion. Right. So again, notice here, not nearly as many glands. So this is proliferative. This is proliferative, 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 proliferative. Here's secretory. Here's secretory. Here's secretory. This massive, massive growth with this massive increase in the number of glands. The number of glands and the size and shape of the glands are really the dead giveaway of helping you distinguish these two layers. Or these two stages, I should say, not the two layers. All right. When we're talking about layers or sublayers, obviously we have our functional layer, our basal layer, and then our myometrium, the smooth muscle. So again,
Would you
not
say
a,
this
but
one,
I'm sorry, go ahead.
would you say this one is proliferative?
No, based on the size of the, especially if I move this over here, when you look at the glandularization, massive, huge, thick glands where you can see the whole spirals of these glands, the massive amounts of glands, this is definitely secretory. Right? There's the lumen. Again, it's not the best view. This is our lumen, but look at the amount of glands that are in here. Look at the difference in size between the functional layer and the basal layer.
So the endometrium should also be a lot larger in the secretory phase?
Yes, absolutely. The endometrium, especially the functional part of the endometrium, but yes, the endometrium in general is going to be much, much larger during the secretory phase. Yep. One more. Again, big, huge, massive glands. All right. And there you go. That was it. So again, not a tremendous amount you guys needed to know for those, but those were the last few things that I think. I think that's everything on your histology list now, yes? I don't think you're responsible for the vagina histologically, but again, it'd be easy to recognize, just a non-keratinized stratified squamous epithelial tissue lining the surface, but I don't think that's on your list. So again, you guys have the list in front of you. Anything else on your histology I didn't cover? All right, excellent. Then that is all that I wanted to do for today. We finished reproduction, we finished the anatomy, we finished the histology. I'm happy to answer any questions you guys have, but like I said, that's all I have for you guys for today. So study hard this weekend. We'll finish up with development on Monday, and then you are done. You will have learned everything you need to know about anatomy and physiology. All right, any questions? All right, seeing as half the people have left already, I'm going to guess no more questions. You guys have a good and safe weekend, and I will see you guys on Monday.